Assalamu alaikum, and thank you very much AFIC for giving me an opportunity to present management of changes in treatment of chronic coronary syndrome according to recent guidelines. It will be consisting on European Society of Cardiology that were updated in 2019, as well as from American College of Cardiology and American Heart Association, which was updated in 2021. So, what change were made? In 2019, the terms chronic stable ischemic heart disease was changed to chronic coronary syndrome. Why? Because we know chronic coronary artery disease is a pathological process characterized by atherosclerotic plaque, accumulation in epicardial artery, whether obstructive or non-obstructive. So it can be either acute coronary syndrome or chronic coronary syndrome. So it was preferred to use the chronic coronary syndrome rather than stable ischemic heart disease because there was ambiguity. So it can be have a quiescent phase. In between, it can have acute coronary syndrome. But if the risk factors are well controlled and the patient is vascularized during acute coronary syndrome, most of the time the patient do well. In other terms, which was changed, the term typical, atypical, which was used for a long time, it was changed because of the ambiguity to either the pain has to be cardiac, possible cardiac, or non-cardiac. So this was another change that was made in 2021 guidelines. So we can have these six scenario in chronic coronary syndrome. Either we can have suspected coronary disease, which is stable inguinal symptom, or with dyspnea. We can have a patient with heart failure or LV dysfunction and suspected coronary disease. We can have patients who is stabilized after acute coronary syndrome or after revascularization for less than 1 year. We can have patients who is stabilized for after revascularization or ACS for more than 1 year. Patient we can have vasospastic angina or microvascular angina, or asymptomatic patient which are diagnosed during screening. So for diagnosis of chronic coronary syndrome, we have to follow these 6 steps. The first steps, which is very important, to assess the symptom and perform clinical investigation, and the main goal is to rule out any acute coronary syndrome. If the patient has got a feature of acute coronary syndrome, we have to deal it according to acute coronary syndrome algorithm. The second, we have to look for the comorbidity and quality of life. If the patient is bedbound, patient has low life expectancy, then revascularization will be considered futile, so we have to do medical therapy and no further investigation is required. Third, we have to do all the baseline investigation like ECG, biochemistry, chest X-ray, etc. And if the patient has got EF of less than 50, and there is less likely that the patient is this is due to coronary artery disease, so then we have to treat the patient according to heart failure guidelines. The third important, fourth, we have to assess the probability of and the likelihood of chronic coronary syndromes. For this, we have to do pretest probability testing. And the fourth, we have to choose which tests to do in which patients. And finally, when we have done and diagnosed coronary syndrome, then this is the treatment. Previously, as we know, the Forrester and Diamond chart was used, but they overestimates the probability, and more patients were included, and more invasive, non-invasive testing was done, and it was found that no, there was non-obstructive CD in majority of the patients. So with time, there were changes, and more clinical as well as recently the calcium scoring was added. So this is the latest one. We can see the dark green. If the patients, according to this probability in the dark green, the probability of having coronary artery disease is more than 15%, then we have to do further investigation. In the light green, if the probability is less than 15, then we have to decide, individualize. If there is some compelling indication, we have to do further testing. Otherwise, no further testing is required. If we add calcium scoring, it will further enhance the probability, and we can correctly advise the test and rule out obstructive CAD. And another thing which was added in 2019 European Society guidelines, which was called probability modifier. These are the risk factors for coronary artery disease. If we add these modifier, there is more chances that these patient, we can detect patient with obstructive CAD. Another change, previously we know that ATT was considered as class 1 recommendation, but in 2019 European guideline it was degraded because there was more false positive and less obstructive CAD was found with ATT, so it was degraded to 2B. Low risk patient testing is not routinely done, but if there is some obstructive, for example, patient is having some family history or risk factors, then we can consider calcium scoring. It will enhance in the finding of obstructive coronary artery disease. If the low risk, because in low risk patients, the chances of having obstructive CAD is less than 5%, and the annual mortality will be less than 1% if you leave it as such. So once we have done with pre-test probability, then we have to which test. If the patient has got low pre-test probability, no testing is necessary, or we can do optional atherosclerotic risk factor stratification or CEC calculation. If the patient is young and less than 65, there is less chances of obstructive CAD, CTA is preferred. If the patient is more than 65, and the higher chances of obstructive CAD, then stress imaging should be done. Now, choosing the test, we have to keep a certain parameter in mind. For example, if we want to do CTA, there should be a low clinical likelihood of obstructive CAD. Patient characteristic is important. For example, patient should not be in atrial fibrillations or obese. Local expertise should be available, and there usually these patients should not have history of coronary artery disease. If the patient has got high clinical likelihood of coronary artery disease and revascularization is most likely, then imaging is preferred test. But if the patient has got high symptoms which are refractory to medical therapy, then we should go for invasive coronary angiography and also do the LV functions. We can do 2 or more simultaneously as well. So once we have diagnosed the coronary artery disease, then we have to decide the treatment. Now, indication for revascularization, it can be either longevity to improve the prognosis, or it may be a symptom to resolve the symptom. Now, factor deciding in revascularization is extent and severity of disease that we can know from coronary angiography. For example, if the patient has got left main disease or not, multi-vessel disease, single vessel disease, and we can calculate Santac score as well, and we can do echo to see the LV function and diabetes. Santac score, previously it was 2A recommendation in ACC AHA guideline. Now it has been degraded because there was less benefit, and it may be done, and it is now 2B. Before initiating any treatment of revascularization, we have to make sure that shared decision making and informed consent is done. Informed consent, clinician provide available evidence for the treatment option, including the risk, benefit of each option. Okay. Patient-centered care treatment, because we have to keep in the patient value, patient preference in mind. Once it is done, then we have to inform the stakeholders about the decisions. This is a bit busy algorithm. If the patient is symptomatic, it goes to revascularization. If the patient is having no refractory angina, then we have to rule out the left main disease. If the left main disease is there, then we should make sure whether it is complex left main, distal left main bifurcation or not. If this is complex left main bifurcation, then cabbage is preferred over PCI. But if the patient has got complex left main and he or she is not suitable for cabbage, then hard team approach, and once it is done with hard team approach, then we can consider for PCI versus optimal medical therapy. For multivessel disease, if there is no anatomy is suitable for cabbage or PCI, then we have to see what is the LV function and how much is the anatomy is complex. If LV function is less than 35, we should go for cabbage. If it is between 50 and 60, it is reasonable to go for cabbage. But which has been downgraded from 2011, if the patient has got triple vessel disease and LV function is normal, then PCI or cabbage is equally good, but it is reasonable to do it. So why it was happened? Because we know from this trial, Courage, Murree, ischemia, and now the Revive trial, we even don't know whether it will affect in future guidelines on the management if LV function less than 35, because in Revive we did not find any benefits. But most of the patients in Revive trial, they were asymptomatic. So these are the trial we can see. There was no mortality benefit, but if you see in the last column and row, majority of the patients were switched from medical therapy to revascularization. So this is almost a second last slide. So if the patient comes to you with chest pain, and angina is severe or accelerating, the patient goes to invasive angiography. But if the patient is having no accelerating angina, EF is more than 35, then we should do these stress testing. If it is abnormal, severe abnormal, again goes to angiography. If there is moderate to severe ischemia, then share decision making either to whether to go for angiography or versus CTA. So if the patient agrees, then we should go for angiography. If the patient does not agree, we should do CTA to rule out left main. If the left main is excluded, then we can give a trial of medical therapy. If it's failed, then invasive angiography should be the treatment modality. This is algorithm for dual antiplatelets. 6 months is recommended, but if the patient has got high bleeding risk, then we can reduce it to 3 months. And after 3 months, only P2Y2 inhibitor should be given. Previously, aspirin was recommended. So the take-home message is clinical evaluation is the best tool for evaluation of chronic coronary syndrome. No more use of typical atypical chest pain, and it's either cardiac, possible cardiac, or non-cardiac. Pretest probability based on age, symptom, pretest probability modifier, and coronary calcium scoring is preferred to determine the clinical likelihood of obstructive CT. CTA or stress imaging, or the preferred modality for diagnosis of obstructive CT depending on patient characteristic. Selection of right diagnostic tests for right patient, share and patient-centric decisions. For symptomatic patient, revascularization, either cabbage or PCI. Cabbage preferred for the patient with complex left main or multivessel disease with left main with EF of less than 35. For those patients who has complex left main and multivessel disease based on Santac score or anatomy, if the cabbage is not suitable, then we can consider PCI. For patient in multivessel disease and normal EF, cabbage or PCI may be considered to decrease the event rates. It has nothing to do with mortality. And we don't know about Revive trial, which is recently published in European Society of Cardiology meeting, whether it will change the guidelines or not. Thank you very much for patient listening.